Okay, now let's carry on. The next presenter is Mohammed from Clinical Fellow at Stroke Unit, Southend Hospital in Essex. Now I forward the microphone to you.
Thank you.
Thank you.
Okay, so good afternoon, everybody. My name is Saad. I'm one of the doctors from Southend University Hospital. I work at the stroke unit there. So let's start the presentation. Today, I will be presenting to you an audit that I did at Southend Hospital. This audit looked at the time taken to perform a CT angiogram and how we could improve it in patients who have had stroke. This is my hospital, Southend University Hospital. It's about 1 hour's train east of London. A brief introduction about the clinical aspects of CT angiogram in stroke patients. So in our hospital, whenever a patient comes with stroke, within a certain time window, we try and do the CT angiogram as well as the CT head as soon as possible. The reason is we want to find out whether there is a big clot which is blocking one of the brain vessels so that we can open it up with any surgical interventions if needed. Now, the more time it is taken for these scans to be performed, the more time it will take us to make the decision. And so every second that passes, the brain is undergoing ischemia and your cells, the neurons are dying. So the sooner that happens, the sooner it is good. So the aim of this audit was to figure out whether implementing certain strategies will improve the times of performing the CT angiogram. Time taken from the doctor's request made on the system to perform the CT angiogram to it actually happening in the scanner. Right. This is what the purpose is. The aim of the audit was to request CT angiograms, first of all, only when clinically indicated. We don't want to perform CT angiograms for a patient who has not had a stroke, for example, or if that patient is outside the time window in which we can perform thrombectomy, the procedure which is needed. By reducing the number of CT angiograms requested without indication, we would therefore save time and resources during time-sensitive stroke emergencies. We would also reduce the number of CT angiogram scans performed without indications. This study also aimed to investigate the effect of radiological wetting on the time taken to perform clinically indicated CT angiograms for patients eligible for stroke procedures. Many of you might already be aware what wetting is, but I'll give you a brief overview of what it is. Whenever we want to perform a scan of radiological imaging, it's not just directly happens, the doctor requests this and it happens. The moment you request it, you need to speak to a radiologist, a doctor who specializes in radiology. And you need to convince that doctor that the scan is actually needed. So if that radiologist thinks, okay, this scan is appropriate, then that scan goes through, then the radiographer in the scanner does the scan. So one of the aims of this audit was, what if we took out this period of vetting from the picture? What if we just request the scan, and if it's appropriate, then it goes directly to the scanner and we get the scan done. We don't need to talk to the radiologist to convince them that the scan is needed in this emergency situation. And lastly, this data could then be used to plan action to reduce the time taken to perform it in time-sensitive situations. So how did we start it? So this was the initial performer that we made. This is the locally created performer, and we used this to collect the data like time taken to perform the CT angiogram and whether the indications were fulfilled for that scan. After this initial period of collecting data over 2 weeks for 14 patients, we then repeated the cycle only after implementing certain strategies to reduce the time taken. So I'll show you what that was. So here, for example, you can see when was the time that your CTA was done? When was the time CTA was completed? We record that. When was the time it was requested in the system? We recorded that. And then we compared how long was the duration of the time taken between those. So once we have done this cycle and we have recorded, okay, this is how much time it is taking if we speak with the radiologist about every scan, what can we do to make it better? What can we do to make it quicker? So the first thing we did, we made a performer. Now this performer has the indications you need for the CT angiogram to be performed. We got this checked with the radiologists, with the radiographers, and the stroke team, and everybody agreed, okay, if the patient meets this criteria, you don't need to speak to anybody, just directly bring the patient into the scanner for the CT angiogram. We implemented this. Secondly, we did a teaching in our own stroke unit, made sure everybody was educated about what are the right indications for performing CT angiograms. And lastly, we sent out an email as well to our entire stroke unit, again, giving education about what are the correct indications to perform the CT angiograms. So what were our results? During the first cycle, 14 patients were eligible for inclusion into this audit. 11 out of 14 patients who were discussed with the radiologist were not refused. So even the radiologist initially agreed, okay, you don't need to speak with us, just take the patient into the scanner. After this initial audit, for adherence to the indications for CTA, initially only 57%, 8 patients out of the 14 met clinical indications for the CT angiogram. After our intervention, this improved to 92.8% adherence to clinical indications, which means more scans were ordered which were actually needed instead of not needed. As for the mean time taken to perform the CT angiogram from the moment you request to the scan being performed, in the first cycle, the mean was around 51 minutes from the time you request it into the system to the time it's performed in the scanner. And after the intervention that we placed in, after we removed the radiologist from the picture, this time was reduced by 20 minutes to around 31 minutes post-intervention during the reordered cycle. So in this picture, you will see adherence to clinical indication. Out of the 14 patients in the first cycle, 8 patients fully met the criteria for the CT angiogram. 6 patients did not fully meet the criteria for the clinical indications, still they had the CT angiogram done. We wanted this to improve. We wanted less people to have the angiogram when they don't really need it. And so after our intervention, in the next cycle, for our new 14 patients, 13 patients fully met the criteria, and only 1 patient did not meet the criteria for the CT angiogram. This is the effect of removing the radiological wetting from the picture. So the above line, the top line shows the times it's taken in the first cycle when you're still wetting with the radiologist. You can see generally all the times are greater than the times in the second cycle when we remove the radiologist from the picture and the scans are done much quicker. And so the same thing which I mentioned, the mean of all this data before intervention, post-intervention, the mean before was 51 minutes from the moment you request to it being scanned. And after intervention, it came down by 20 minutes, 31. Conclusion, using education via email and departmental teaching, improvement was first of all seen in adherence to clinical indications when requesting CT angiograms, an investigation which need not be used unnecessarily, given the possible side effects of contrast, radiation exposure, and resources used. And this led to reduction in the CT angiograms ordered, which did not meet clinical criteria for thrombectomy. And furthermore, by implementing a proforma, which was agreed within the hospital to proceed with the CT angiogram in time-sensitive thrombectomy scenarios, mean CTA time was reduced by 20 minutes. Now, this is a lot of value for patients who present with stroke, because every second that passes, their brain is dying off. So every minute counts. That's it. Thank you very much. Yeah.
Thank you.
Yeah. It's a very good point. You know, the moment you try to improve something, you have to go through a lot of hurdles, especially in NHS. So, but I think what helped in this matter is because we're removing the radiologist from the picture, we have to somehow appeal to them as well, make sure they're not mad about us removing them from the picture. So we have to talk to them like, look, we are not ordering extra scans which are unnecessary. We're actually improving the number of scans which are being ordered unnecessarily. So that was an incentive for them to get involved. They said that, all right, less scans will be ordered which are not clinically indicated, so we can become a part of this. So then the radiologists came on board, and then our stroke consultants anyway, they were on board as well, because this helps us make the scans happen faster. And so like that, this whole thing came together. Yeah.
Thank you.
Sure.
Thanks again.
No worries, thank you.
Then let's move to the next presentation. By Asghar. Asghar is currently doing a PhD at the University of New York.